Psychological trauma is one. Now feeding is a problem, and so is chest infection because of the regurgitation of the milk. And if there is a chest infection, so the prime focus with newborn is to keep the child safe, to make him survive, and to have his weight gain normal. Like Dr. Sidhu mentioned that surgery can be done only if we follow the rule of 10. So if he doesn't feed, if he gets chest infection, he doesn't gain the weight. If he doesn't gain the weight, surgery cannot be done on time. Surgery is delayed. And anesthetist will not give permission to do surgery because of the chest infection. So the first focus is to reduce or not even have the chest infection by proper feeding. Then you have usually primary surgery, but primary surgery can be with complications. There can be secondary infections coming out of primary surgery. Now, as the child grows, suppose everything is going well, you had a primary surgery by 10 weeks, which is rare in our Indian setting. I will show you the data. But after that, you go to surgery of the palate. For the surgery of the palate, earlier concept was if you delay the surgery, then the growth is better. But now they say if you delay the surgery up to 5 years, growth is better, but speech is bad. And now they consider that speech is a better, more important communication tool than the growth, which can be controlled by an orthodontist. So now they used to do like palate surgery by 1 year. Now they are doing it 18 months, then 1 year. Now they are doing by 10 months. Everything goes there. So the time of surgery is becoming shorter for the palate. So primary surgery for the lip and the surgery for the palate. But what happens that these all patients get recurrent infection of the middle ear because of the abnormal positioning of the tracheal tube. And because of that, they have problem in the hearing. And that delays the learning of speech. And what happens usually what happens in our society, अगर क्लेफ्ट का बच्चा नहीं बोला करता, नहीं थोड़ा स्लो है, सीख जाएगा, बोलने लगेगा, बट वो बोलने तब लगेगा जब वो सुनेगा, अगर उसको सुनाई नहीं देता तो बोलेगा कैसे? And there are some children who are born with primary deafness, congenital deafness. That is also another entity which may be part of the cleft or may be independent of cleft. It could be associated or may not be associated. Then around this time, 3 years of age, when the patient is learning to speak, there is also issues with the oral hygiene, because most people think that since he had surgery of the palate, since he had surgery of the lip, they don't give him normal food, and they try to give him sugar saturated beverages. So he is getting more sugar than what he should. He is not getting enough oral hygiene, so they tend to have more proneness to dental caries. And then sometimes the surgery of the palate is incomplete. There is a development of fistula. So the child has a complaint of regurgitation of food. Now fistula may be symptomatic or asymptomatic. So there may be fistula with no symptoms, but there may be fistula with symptoms. So if there is a fistula with symptoms where the liquid fluids are going in the nose or the food is going in the nose, then it is a matter of concern. And even if you have sorted this out, there would be still residual surgical scars in the lip, and they start appearing on the nose. And when child goes to school, he is ridiculed for that. So then the psychological disturbances come in. And then you have to take a decision at this stage whether revision of the lip should be done now or not, or should it be done much later, because it will depend upon child's and parents in society where they live. And as the child grows, because of the scarring, pressure from the lip, scarring of the palate, the growth of the maxilla is hampered. Now when the growth of the maxilla is hampered, it is hampered in the all three planes of space. There is a deficiency in the height, there is an anterior-posterior and width. That means maxilla gets repositioned backward, it doesn't grow in height, and it doesn't grow in width. So there is a tendency for anterior crossbite, there is a tendency for posterior crossbite, and there is a tendency for sometimes mandible to overgrow. Or sometimes, because of the anterior crossbite, mandible has no hindrance to stop. So mandible overgrows. Mandible overgrows. Now, it is also known that most cleft children would have missing lateral incisor or rudimentary lateral incisor. So you need to see that sometimes you mistake these rudimentary lateral incisor for a deciduous tooth. It is a very common mistake. And you have to spend time again and again to be sure whether it is a baby tooth or it is a rudimentary permanent tooth. Or it is an extra tooth. Sometimes there is supernumerary tooth. Now in cleft patients, you could have both at the same time. You could have hypodontia and you could have hyperdontia. In one segment, hypodontia and hypodontia. And why it happens? For that, you have to perhaps read something more. We'll talk about it later because it is the time of programming cell death when it occurs, whether it causes dichotomy of the tooth bud or it kills it completely. So you have to read one article of mine in Medical Hypothesis, published many years ago. And as the child grows bigger, so now nasal deformity starts appearing more. Up to now we're talking concerned about this. Now if it was UCLP, then it is the nostril size and the shape of the nostril and the ala and the dome and the tip. Everything changes, the nose changes. Now if you have abnormal nose, you can imagine how the child is affected. And even if you have done all this, you have corrected all this, child still has a mutilated dentition. You have done the expansion, you have done lip surgery, you have taken care of the growth. So you have to now look for occlusion. It will require occlusion rehabilitation, which may be in the form of veneers, which may be in the form of a bridge, maybe you have to do an implant and those kind of things. And even if you have done everything, you have now, child looks normal, but still he has some social and psychological issues which he has gathered over the years. He is not completely out of it. He always thinks that he is not normal. And then it is planned for him to go for marriage. And when he thinks of marriage, he shivers because he and she may think that first thing is whether I will get accepted in the family because I am a cleft, I am a deformed patient, even if he looks normal. And two, his speech may not be absolutely normal. The speech is a key issue. In aesthetics you can restore, but it is the speech, if it is not taken care at young age, at the time of development of speech, it remains very big issue. And the third issue is that even if they are able to find a partner, and they may find a partner who also has a cleft, that is the other problem. A cleft may think, यार जैसा मैं हूँ मेरे जैसा ही मिल गया, गाड़ी चल पड़ेगी, पर वो गाड़ी तो चलेगी पर गाड़ी आगे की गाड़ी गलत चलेगी, because then they have a very high chance to have cleft sibling. So cleft child. So that is how the problems are. So they may come back to you again for counseling. So the problem, components of the problem is very large. Very large. The spectrum is very different at every stage of life, and you need different kind of specialists. As an orthodontist, you are not answer to all the problems, but you are answer to a problem that you work like a glue for all the specialists. You are the key man because you are the person who is most approachable, who is available, who doesn't do much harm because they are scared to go to surgery. You ask every child that we need a second surgery, he will think, is it necessary? Should I do it again? Oh my God, again I have to have anesthesia. They are scared, they are frightened. But with the orthodontist, they think he is different. So that is why in American Cleft Palate Association you will see, and all Cleft Palate Associations have multidisciplinary people. Speech, people are speech, orthodontics and surgeons. And in many places, in many clinics, it is the speech therapist who is the coordinator of cleft clinic or the orthodontist and not the surgeon. Because speech therapists are also good people in the sense that they are docile, they don't do much harm, and so is the orthodontist. So, in a nutshell, what I conclude from what I have talked to you in a few minutes is that a cleft child is handicapped. And he is handicapped in what way? He is handicapped because he cannot communicate efficiently. His functions are compromised, maybe because of deafness, because of partial lack of hearing, because of mastication. He is psychological handicap because of the poor aesthetics and also speech. And one more thing which is mentioned here, respiration/OSA, that all these children with cleft are sometimes are prone to have more obstructive sleep apnea. And sometimes the reason for this OSA is very simple, and that is the enlarged turbinate. If you look in the cleft child's nose, you will find his turbinate is enlarged and has blocked the other side of the nose completely. And just turbinectomy will clear their nasal passage. So they have also tendency for high obstructive sleep apnea. Now, for example, this lady who is with us now had a bilateral cleft, as you can see this, which is kind of an incomplete. And that the picture which is on the adult is how she looks like. So the objective of the team or the cleft care is that if you can bring these children to somewhat near that or somewhat near that. She is also one of our cleft patients, very old patient. See, I am now treating the second generation of this girl. And they become, I will show you the whole history of the treatment of this case, and this is another one. Her name is actually Priyanka Chopra. And she is no less, because every girl is Priyanka Chopra for herself. कहते मैं अपनी खुद की most favorite हूँ. There was a dialogue. Which movie was this? I have forgotten, but I think Rashma said it. Huh? जब we met. Okay, yeah. मैं अपने खुद की favorite हूँ. Yeah, until unless you respect yourself, you will respect. That is the way it is. So, first you have to have your self-respect. So, that's how it is. So, I work here, you know that, and you know that we just celebrated 60 years of AIMS contribution to the country, and that is where Dr. Sidhu got that Lifetime Achievement Award. And you know where AIMS is. And this slide is important, 1996. It is important for me particularly because on this so-called World Congress on Orthodontics and 31st Indian Orthodontic Congress, which was held at Hotel Ashok, what you see here is that you see Dr. Jana, you see me there, you see Dr. Shetty, this is K.K. Chopra, and this is the guy who is the one who has promoted serial extraction, Dr. Dale. He was here. He is the president of the American Association of Orthodontists. I don't remember his name now, but his contribution is in functional appliances. So what I wanted to show was this. So in this conference, Dr. William Shah, with whom I worked under him as Commonwealth Fellow, and his wife Gunvar Sen, they decided to come and give a symposium on cleft palate in this conference. So it was, I think, historical moment in the history of Indian Orthodontic Society that a cleft orthodontic symposium was held. So when I was coming in October, I finished and I requested them to join, and I was not getting very positive response from India, Indian authorities who were organizing the IOS conference, and the response was lukewarm. And I was sending mailer again and again and again. Then Dr. Shaw told me that, Dr. Kharbanda, you are so persistent that we should come. So we are willing to come, but I think we should come when you are in a better position to invite me. You are still young, you cannot influence people. You are not in a position to say this should be done and it will be done. Maybe we'll come some other time. But my perseverance was so great that I could convince Dr. Jana that time that we must have them and convince them to come at their own cost. Because main issue was the cost. Who will pay the cost of their travel? And they are also like non-practicing orthodontists, like we in names, like we are like public servants. They were also public servants because they are working for the NHS. So वो इंग्लैंड में रहते हैं तो इंग्लैंड वाले खर्चे, हम हिंदुस्तान में रहते हैं हिंदुस्तान के खर्चे हैं, तो सरकार नहीं। So, but they decided, they spent their own money and they came, and which I cannot forget. For that, I really appreciate that. And this man was good in many things, including singing. So now we want to know that how much is the burden of this care. We know that even single patient has so many problems. So you imagine that the cleft palate is part of the birth defects. It has been briefly already mentioned, and birth defect is not only cleft. There are so many birth defects. And perhaps you may be aware or not aware, there is a program by Government of India which is called RBSK, Rashtriya Bal Swasthya Karyakram. Are you aware about it? I think you should go to the website. And in that RBSK program, the defects of birth are being recorded. And cleft is included in those birth defects. So according to, and the data is still to come actually, there are about 8 million people, which are 6% of the total newborns, have birth defects. 8%. And about 2 to 3% of them are, I'm talking birth defect of the whole body, which includes undescended testes, your cleft foot, spina bifida, everything. But limited to this area are 2 to 3%, which is a lot. And cleft is part of the craniofacial birth defects. And when you look at global scenario of cleft, unfortunately the cleft is more in poor countries. Now, when we talk about cleft per se, we usually talk about two types of clefts. The clefts which are non-syndromic and clefts which are a component of some of the other syndrome. Cleft is not the primary disease. So, if you see 10 cases of cleft, the possibilities are at least 1/3 of them could be associated with some syndrome. Sometimes they are associated with some disease which you can't see. For example, they may have a small hole which is called between the two sides of the ventricles. So very small hole, but it eventually heals up. But there was a syndrome. So they may be part of the syndrome or they will be non-syndromic. And among non-syndromic, that is what we deal with most. There could be cases which are limited to cleft palate or cleft lip and cleft. Now these are two distinct categories of cleft. I remember when we sent our first paper of Dr. Rupa Raghavan on, she did a study on the pattern of normal parents of cleft children. The children who were normal, the children with cleft and their parents. So we studied their parents. And when we sent the data to that time, Dr. Turpin used to be the editor of Angle Orthodontics, David Turpin. We sent the data, we got the paper back. They told us that why did you club the parents of cleft palate and cleft lip and palate together? They are a separate entity as far as genetics is concerned, as far as their development is concerned. So whenever you do research with cleft, you make them into two categories. Because cleft palate only is more genetically controlled as compared to cleft lip and palate. Okay. So, and that is why if you have cleft palate, at least 50% of them are syndromic and 50% of them are non-syndromic. But in cleft lip and palate, only 5% are syndromic. So if you are getting a patient with cleft palate only, you look it more deeply, investigate it much more than you are looking at a patient with UCLP. So the terminology which I mentioned to you before has been used in names, and we have carried this terminology over the years, which includes, if you have, maybe I will show you a representative case and you can understand better. Cleft of the lip, CL. Now cleft of the lip can be in a microform. Sometimes you will see somebody, you think there is cervical scar, but it was not a scar. There was a cleft which was to happen, but it did not happen. And it can go from a very minor to little more to pull. So you have cleft of the lip, CL. And then CL could be that way. You have seen the spectrum. Spectrum of cleft patients can be very large, from this to that. Then it can be both sides, bilateral, BCL. And you could have cleft of the lip and alveolus. That is called UCLA, unilateral cleft lip and alveolus. You see in this case. And then this UCLA could extend deep into palate and the short palate. We call it UCL, unilateral cleft of the lip and palate. And when it is on both sides, it becomes BCL. So this is a terminology which we use, and we at AIMS we have not used any other terminology as of now. We are not using any classification other than this. And this I have inherited, and I am happy with that. Sometimes you have cleft of the palate, like this one or this one. Now there are also clefts which are called midline clefts. I have not seen a case of midline cleft. I don't know if Dr. Vareja has seen. You have seen one in line? Dr. Sidhu has also. Why we have not seen, but it is the entity. Can you tell me the reason? The reason is that when there is a cleft of the midline, these patients not only have lack of union here, they have lack of union even in the heart, in other parts of the body, and in the brain. So most of them have stillness. So they don't come to an orthodontist. Or they die within first few weeks or few months of it. Survival is very low. But I came across one plastic surgeon in Delhi, lady plastic surgeon, who met me at our cleft conference when we organized that day. She said that she has a cleft who has survived and she has operated. And she carried that picture with her in the pocket, the person. I said, ma'am, why don't you share this with me? I will publish with your name in my book as an example or show it. She says, no, I'm sorry, I can't part with this. So she did not want to share it, but I was very keen to take that picture of a real cleft in the midline because I have not seen it. Now, if you look at their distribution, the UCLP is the commonest. Sometimes you get this MCQ, which is the most common cleft. So UCLP is the most. And which is the least common? Cleft of the lip alone. And you have followed by CP, followed by BCLP, followed by cleft of the lip, and sometimes there are permutation combinations. Okay? They are common. Now, surprisingly, the cleft of the lip occurs more on the left side, UCL. Why, nobody knows. I think it is a PhD project that somebody wants to take. And it is more common in males than in females. But the cleft palate is more common in females. Fantastic. You already got the answer. And this picture which you have, all of you have seen as undergraduate, is nothing great about it. But what I am trying to again re-emphasize here is that it is lack of union and not splitting of an structure which causes cleft. So lack of union between nasal process and the maxillary process. Very simple. So if you look at this one, next one, maybe I will show you this one. The union starts from the front towards the back. So if you see only cleft palate, that means the insult or the problem occurred much later in the uterine life than in the cleft of the lip. And sometimes you see the problem on the cleft of the lip. So there was a transient problem and then it survived and it did not remain later. That environmental insult was not that longer to sustain it to the development of the palate and the fusion. So the palatal fusion or the fusion of the processes starts from the front to the back. That is one. The second thing is here, what you see in this one here is that it is lowering of tongue as the face growth occurs during first 6 weeks of life is very important. It is the first 6 to 8 weeks of intrauterine life is the most critical period as well as development is concerned. If it does not lower down the palatal fusion, cannot ascend. So that is very, very important. So now there is a man called Murray. He is very famous for cleft genetics and development of the cleft. If you see his work and what he is trying to say here in these line diagrams, which are pretty simple. Now something more important here is Simonard band, which sometimes you will get a question. The presence of a Simonard band in a UCLP will lead to better growth of the maxilla, poor growth of the maxilla. It will lead to surgical complications or any other. So what is Simonard band? Simonard band is that sometimes this epithelium does not break down completely. It remains like a band between the lesser and the bigger segment of the cleft, between these two segments here. And when the child is born, there is a strong band. So presence of Simonard band leads to better contour of the occlusions because it acts like a rubber band between the two segments. So in this regard, when I was working in Australia, one of our postgraduates, Dr. James Choi, with the genetic department and we together had planned some study on rat mouse, and what we did that we dissected the rodent embryos prior to and during immediately, and prior to, during and immediately after palatal fusion. That is the postcoital 14.5 to 6.5 days postcoital. So what we were trying to see that what happens to the epithelium layer which covers the palatal shelves, and what is the process which makes them become one, because two palatal sites have to become one for them to become a single palate. So what we found, this was the situation, as you see, we have seen in the slide diagram that there are two palatal shelves, there is a tongue here, and this tongue goes down and the palatal shelves start coming closer. Now these are the pictures of real dissected embryos. And as they come closer, what happens that this epithelium starts to break down, and this process is called EMT, ectodermal mesenchymal transformation. So if EMT doesn't occur, even if the palatal shelves have come closer, the fusion will not take place. So the EMT is an essential component of becoming the two halves of the palate into one. So there are situations which there are pathways which does not let the EMT happen, and one of the pathway comes from folic acid. So we will talk about it in the etiology. So if EMT does not happen, the palatal fusion will not happen. Now, this is very, very important area, which tells us why cleft lip and cleft palate are two different entities in terms of etiology and in terms of development. You can read this first maybe. If you have to justify that why the cleft palate only is more in females, it is because in females the palate formation takes longer duration to fuse as compared to men, and therefore they are more liable to environmental insult, and that is how females have more cleft palate than males. That is one. The second thing is that when it is cleft lip or palate, it is inadequate migration of neuroplast cells and excessive cell death. But here it is the tongue which is more responsible. If tongue doesn't lower down, palatal shelves can't close. But here tongue has a very little role. It is the medial nasal process and the maxillary process which are more responsible. Now, the teratogenins or the anticonvulsant also have lot of effect on palate. In cleft lip, vitamin A has lot of role. Some girls are taking those for pimples, those medications, Accutane or something, trying to convey only one thing, that there are vast number of genes which are responsible together for creation of cleft. But one thing more it is clear that cleft is also an indication of absence of lateral incisor. Knockouts have shown 100% formation of cleft palate. So that establishes the role of these genes in the formation of cleft. Something more interesting. There are people who always have cleft, but if you give them this, their cleft fuses. And this work has been done in chicken. So this further proves that transforming growth factor beta 3 has a significant role in the formation of cleft. Something more interesting. So what would you expect if there are monozygotic twins? Should both of them have cleft or both of them should be normal? If one is normal, what do you expect from the other? Normal. But that is not happening in case of cleft. In cleft palate patients, there is no 100% concordance with the cleft. I think 5%, if I am not wrong, 5% is the data. There will be some slide there which will show that out of 100 monozygotic twins, if there are monozygotic twins of cleft, 5 would differ. That means one may have more severe cleft or less severe, or one may have cleft, one may not have cleft. This amounts to what? This says that it is not only the genetic factor. It is not only this, because there could not have been better genetic pattern than in monozygotic twins. That is the best you can say experimental model or study model you can think in at all. And if monozygotic twins, among monozygotic twins there is a variation in cleft occurrence, that means there is a factor other than genes which is affecting. So that means where this second twin is placed, what kind of insult he is getting, whether his blood supply is getting compromised due to some reason, due to pressure or something, we don't know, is that the reason. So then it has been also shown that on ultrasound studies that the rate of growth of the face is different even among twins. Among environmental factors, micronutrients are very, very important. And the important micronutrient is of course folic acid. But here one study which has come from Philippines, where there are population which live in socio-economic low status, poor people. When the incidence of people among those, some of the group moved to US in California, the incidence of birth defect changed. So there are some studies which say that change in the socio-economic status leads to less formation of birth defects. That means micronutrients play a role, because if you are poor, you are only eating few things, you are not eating everything, you are not eating balanced diet. So high doses of vitamin A I have mentioned before, but I think most important here is folic acid, and I think the country is going to have some folic acid policy now. It is in making, because there was a meeting only a few days ago, and I have really stressed on it. Some work is coming up on this. Smoking, because of hypoxia, and one factor which is more now being investigated is chula. Does chula, cooking on chula leads to availability of more carbon monoxide, means less oxygen saturation to the developing embryo, and that will lead to birth defects. So that is also a matter under investigation now in a very serious way. So other than the drugs, particularly antiemetics and corticosteroids, anti-abortifacients, so all these drugs have to be taken with caution. Thalidomide is of course already very well known. Smoking and alcohol fetal syndrome. Now, other thing which is very important is that woman, when she knows she is pregnant, she stops smoking. concerned about my baby. I'm too much concerned. I want to have a perfect baby. But she does not realize that by the time she realizes that she is pregnant, it is already 6 to 8 weeks. And she had conception when she was smoking very heavy and she was on alcohol. So what does that mean? That means the damage already occurred. So if a benefit of non-smoker has to occur, or alcohol-free availability has to happen, then it has to happen that any woman who thinks is going to be a mother should keep herself deprived of the ill effects. Then only the benefit will transfer to the embryo. So folic acid has a very significant role in particularly in neural tube defects, including cleft lip and palate, and this has been investigated by Siegel from Poland, and the study is also from California. And the other thing is that the benefits are dose dependent. So it has to be almost 4 times the conventional dose if you want to have the therapeutic efficacy of, which becomes almost 3 to 9 milligram per day in early post-conception. Early. So this is about Philippines. I think I have already mentioned about this slide, what happened in Philippines, that how the incident happened. And here, this may not be very visible to you, but one thing I have placed this slide here because I just want to show here that with folic acid supplement, there was an 11% reduction in cleft lip and neural tube defects. This is the most important. Like some of these studies have shown that is the kind of benefit which you can get. Now, you know that the gene and environment, they interact, and in the body there are some genes which are specific to certain environmental insult, and this is the list of those genes, and maybe this is the most common 2 words which are being often asked in the embryo synthesis exam as well, that which is associated with this, and these are the also genes which get affected with the environment. And the speech therapy keeps on going till 10 years. But the intensive speech therapy is only during this time, younger age. So younger the better. Then it comes the secondary alveolar bone graft. Now the bone graft is done for 2 reasons. Either to bring the lateral incisor to erupt it through if it is not bone around it and if it is in the cleft area, and also the canine. So sometimes it is for lateral, sometimes it is for canine, or sometimes it is for both. So this will depend upon anything between 8 years to 11 years. That is SABG, secondary alveolar bone graft. And then the orthodontics. Now the role of orthodontics starts at what age? Usually at as early as 6 years with the eruption of incisors, when we do not want these incisors to be in crossbite. We don't correct rotations in cleft patients because these rotations we don't correct because they are usually next to the cleft. So we only correct the crossbite so that the mandible is contained within maxilla. That is the idea of it. So orthodontics starts at 6 years, then comprehensive occurs just before bone graft, that will be pre-bone graft orthodontics, then post-bone graft orthodontics, then comprehensive orthodontics, and then you finish the case. So orthodontics will go for many years, starting from 8 years to say 18 years. And if there is an orthognathic surgery, this will be only orthodontics, and this will be in combo with orthognathic surgery. If patient is for orthognathic, again you have to do orthodontics. So that is the, you can say, a schedule and protocol, ideal. This is ideal, but it may happen, it may not happen. You know there is a team, but the key players in the team are usually 3 people, the plastic surgeon or the cleft surgeon, the orthodontist and the speech. And everything else falls around it. And sometimes the important people are also the nurse, and she is important, especially in the beginning of life, to teach feeding and also to prevent chest infections. The Prosthodontist becomes important at adulthood. Maxillofacial surgeons, in some places the maxillofacial surgeon is doing the bone graft, in other places plastic surgeon, but he certainly does the orthognathic surgery. Speech and ENT people are very, very important. And then question comes, who is a cleft surgeon? Cleft surgeon is the one who is competent to do cleft surgery, to create a functional lip and functional palate. Because suturing of the cleft is not like stitching two parts. So functional would mean what? Functional would mean that the soft palate functions for the purpose of respiration, for the purpose of swallowing, for the purpose of speech. Similarly, the lip should give a good lip seal, so that if there is no lip seal, there is no good development of speech, there is escape of air. So functionality we'll talk about it. So he is the cleft surgeon. Now, if you look at the protocol at birth, the problems are feeding and chest infections, and what I have told you this already. At 10 weeks, aesthetics is important, so lip and anterior repair is done by plastic surgeon, and during this time, if you are suspecting an congenital deafness, then you need an audiologist. Around this time, speech, and for speech sometimes posterior palate repair is important, critical, so it should be done well. There should be no fistula. And then between 3 to 5 years, you start reviewing the eruption of dentition and caries, because here the role of dental surgeon will come and pediatric dentist will be important. Again, you continue with the audiology and speech, and if there is no problem, there is a problem, then you fit the grommets. But if there is a problem, you carry on with the intensive speech therapy. Now, something more important here is that sometimes these children require a surgery of the palate or in the pharynx, which is called pharyngoplasty. Sometimes they require soft palate lengthening. So the type of surgery to be done by plastic surgeon to improve speech is decided by not by plastic surgeon. It is mainly decided by the speech therapist, who would evaluate in joint consultation with plastic surgeon and decide that she will not be able to improve speech with this intensive speech therapy. So you need some better way to bring out the velopharyngeal sufficiency or to treat velopharyngeal insufficiency, then only pharyngoplasty is planned. So sometimes pharyngoplasty is an additional operation which is required for the purpose of speech. And they may do pharyngeal flap or pharyngoplasty, that will be decision by the plastic surgeon, but speech therapy has to continue. Then this looks complicated, but this is very simple. That when you do an orthodontic review, the most important thing here is that whether it is a case which would need a bone graft or it can be managed without bone graft. So if it is without bone graft, that is the time you start also taking the full records of the case, which is called SEF, OPG. There is separate presentation on how to take records, but I will just finish here. And you create a comprehensive diagnosis and treatment plan. So at this stage, your job is to correct anterior cross bite and maybe face mask and maybe chin cup. So now different centers have a different philosophy, but we believe in chin cup a lot. Because when we get patients with cleft, we have to put them on waiting list, but the least we can do is just give them a chin cup. So that at least puts their mandible on hold. When it is 17 years plus, you take another set of records, and as an orthodontist you may like to finish and detail, but if it is an orthognathic surgery, he has already undergone orthognathic surgery and efficient detail. And what plastic surgeon is doing here is that he might have to do rhinoplasty, revision of the nose. And of course, I have already mentioned this, around 20 years, you need a counseling with geneticist who would tell you that how much you are at risk with your family, with your having a baby, with what are the chances of having it.